Welcome back to the Atlas of Chiropractic podcast. I'm particularly excited for this series of episodes. I've got Dr. Cameron Bearder and Dr. Jonathan Chung with me, and there's been a lot of discussion as of late in the Upper Cervical Club on Facebook and the various social media platforms regarding NeckCare. And we did an episode with Ori from NeckCare talking about what that technology offers in terms of assessments of cervical spine function. Dr. Chung and Dr. Bearder and I have been using NeckCare for a little over a year. And one of the things we've realized in observing some of the conversations going on around these assessments is I don't want to say lack of understanding, but questions about, okay, the interpretation of these tests. What does this mean for upper cervical chiropractors? What does this mean for folks that are focusing their interventions to the cervical spine? What do we make of this information with the things that we already know are efficacious in our procedures? And so that's what we're going to talk about today. There are 3 assessments in NeckCare. And for more information on the actual company, the product, the assessments that are available, those sorts of things, reference the previous episode we did with Ori. The link is in the show notes here. Dr. Bearder also did an interview with Dr. Jeff Langmaid, the evidence-based chiropractor, going through some of that as well in terms of the value and communication and how it has impacted his case management and patient outcomes. So go reference that as well. But this is going to be a little bit more just getting into the data and pulling out the gems, so to speak, that are what NeckCare has meant to us clinically and how it has impacted the way that we deal with our patients. So, gents, do you have any information beyond that for an introduction, or would you like to get right into range of motion?
We can get right into it.
Right in.
Okay. And this is the one that most of us are most familiar with, right? And it's funny how even just talking with Ori when I was onboarding and just in general, we all think range of motion is important, right? We all want our folks to achieve a comfortable, natural, symmetrical range of motion. But a lot of the assessment tools that folks use, if they use any, are not very robust. And so I think to Cameron's point on the podcast with Langmaid, there's so much data there that we haven't been able to measure until now. So NeckCare's range of motion initially was maybe the least appealing thing to me. It was like, okay, great, range of motion. I kind of do that already. But it's actually been one of the more impactful assessments for me personally in terms of understanding what's going on. And so right now we're going to pull up a range of motion assessment. If you're listening on the podcast, click the link, go to YouTube to observe the visuals on this, because you're going to want to see the actual assessments in real time and what we're referencing with that. Who's pulling? You got one? Yeah, I thought you had one pulled up. Infinitely editable.
I was about to say, yeah. Do you want me to pull it up? Who's pulling it up? I can pull it up.
Anybody. I'll do it if you don't want to. I'll just find one that I did on myself.
I had mine saved on the JPE, so.
Okay, cool. We'll pull that up for yours.
I've got it. Share screen. Can you see it?
No.
How about now?
It's loading. Yep.
All right, so what we're looking at on the screen here is basically the user interface and the reporting that shows up as soon as you finish your assessment. Okay, so a couple of things to just orient folks to as we're looking here. Up in the upper right hand column, I think the scoring thing is kind of interesting. I don't really make mention of that to folks. I don't make a big deal of it. I might say A, B, C kind of a score, but it does quantify generally what level of improvement on 0 to 100 you demonstrated. So for some folks, that's kind of a nice arbitrary metric to reference. But then we're looking through all of the actual readouts here. So you can perform 1 to 5 reps, correct, on this?
Yes, correct.
Yes, you can do up to 5 reps. I do 3. I think it's interesting to observe if folks improve their range of motion or get worse through a series of repetitions. And it performs flexion and extension, right and left rotation, right and left lateral flexion. Okay. Also, just kind of as an outcome assessment thing, it's really easy to compare results. It'll pull up, previous exams next to your most recent exam, so you can kind of compare side to side with the visuals, exactly how folks are doing. So, right off the bat, when we're looking at global range of motion, right? This is in your exam flow, Cameron. Where does this fit in? I do this as my first exam procedure. Is cervical range of motion with NeckCare, but where does it fit into your exam flow, and how much you talk a patient through this as you're doing the assessment?
Similar to you, this is my baseline. So I will typically start with NeckCare, just like you, range of motion, and then I will use range of motion JPE mainly to help understand what potentially to expect relative to my imaging, which I've talked about in the past. So for this patient, for example, extension, they were restricted in extension pretty much across the board. I would then go and look at JPE and understand if there's a flexion extension JPE issue. I would probably then prepare to take a neutral and flexion extension cone beam. So that would just be my flow. But just like you, I start with NeckCare because we're upper cervical offices. We want to see what the spine is doing functionally.
Right. And it means, symptom wise, like folks might even just lead with something like, man, my neck is so stiff and uncomfortable that like every time I turn to the right, it's clicking or it's catching or I'm getting this shooting pain, right? Folks will kind of lead with some of this information. And I always tell folks like the right and left sides are connected. Just because you feel it there doesn't mean that's where the problem is. So we're going to assess function and see what's actually not working well. And then that gives us an idea, to your point, Cameron, of like, as we build a case through the series of assessments that we do, it really starts to zero in on, okay, by the time we do that first adjustment, we're that much more confident that we've chosen well, and how we want to go about creating a change with the spine. So in terms of the global measurement, right? So we see there's little head positions here and it gives you the three trials there. I tell folks it's one thing to know how far you move, right? We want you to be able to hit the normal ranges and we want it to be relatively symmetrical. We want you to be able to do that with comfort, but then we also want to understand how you got there, right? And so sometimes the global range of motion measurement doesn't give us the whole story. And this is where I think obviously NeckCare really shines. Somebody posted a competitor's range of motion thing on a Facebook group the other day, and it was like, man, that's just, yeah, we get it. It digitally measures range of motion, but this doesn't hold a candle to what we're looking at here. So Cameron just pulled up the accessory movement portion of this exam, which initially when I saw this, I think Ori maybe previewed this, showed us some of this at the forum last summer, and our minds were blown. We're like, wow, oh my God, that's a lot. That's a ton of information. And it seemed a little overwhelming at first, but with some time, I really, really value this. So Cameron, do you want to explain like what are we looking at with the accessory motion here? And then we can talk about what it could mean.
Yeah. So accessory, and like you said, John, as far as I know, we've never been able to see this before, at least quantify it, which is a huge deal. But I remember it was like beta 1.5 software. They didn't NeckCare didn't have the extension. They didn't have extension, flexion, or left and right rotation on this left right here. So it was just the graphic. So we kind of had a little bit of trouble trying to understand like what's happening, but they love feedback. And so we gave them feedback, and now you have a better idea of, let's say, for example, if we look at right rotation, you can see on right rotation that this patient in particular, as they go through the range of motion, they actually end up extending their head during the right rotation, and they do it kind of uniformly throughout the movement right here, right? So you can see as they get towards 68 degrees, they slowly extend their head, and you can stop it right there, and you can see, they extend their head on average maybe like 3 degrees. But what you can also see is that with those 3 reps, they also do a left lateral flexion. And between the reps, they average about, 15 degrees. So as they're turning their head, as they're turning their head right, they're bringing their head down into the left. So that left ear comes down. And so that would be a lot more of a compensatory type of reaction or compensatory type of motion. But this is really important to see as well. If you look right here in that area, what you'll end up seeing is you'll see this kind of squiggly line. That is the patient unfortunately not listening to the instruction of, when you come back to center, hold still and wait until I ask you to move. So when they came back to center from right rotation, they ended up moving their head a little bit kind of back and forth, almost as like this oscillation. And we have to say, oh, hold on, bring it back to center. So that's when you see, and you can see it as well in right lateral flexion.
Right.
These are the variables that we need to know when we're interpreting the data, right? That wasn't this person's head. You still have to watch the patient. That wasn't this person's head doing this, but it was they came back from left lateral flexion and they didn't stop in the center, or they stopped a little bit too far into right lateral flexion. So to me, this is actually almost like a concurrent joint position sense if their eyes are open or eyes are closed, depending on how you do it. But that's a patient error and not necessarily a software error. And I think that's really important. If you're a clinician looking at this for your own patients, you need to be able to pair this and say, oh, that was the patient misunderstanding the instruction, or it was just some sort of variable. But you can see with this patient in particular, even though they had a restriction in extension, pretty significant, right? They had a restriction. If you go and look at the accessory movement, they didn't have any compensation. It was pure extension.
Yep.
Yeah. But in flexion, where it was within normal limits, what you can see is that they, every single time, about halfway through the motion from 30 degrees to about 65 degrees, they started to rotate their head to the left, as well as bring their left ear to left shoulder. So they did this every single time. And what's crazy is, and I love this, I took a cone beam in neutral, and guess what their posture looked like? Exactly what it would look like in an end range position. They were already in this pre-slight rotation, it literally looked exactly the way that the range of motion looks here. The image was almost identical. So they have some sort of static, what we'll call subluxation complex or patterning that is exacerbated through that range of motion.
Yeah, that's a perfect correlate to the imaging, because I tell folks all the time, like, you could have positional issues, you could have movement-based issues. Like for some folks, it's a combination of the two. And we want to understand, like, if we see a change in your positioning on imaging, like, what's the relevance of that? Does it actually impact how you're functioning with the things that are baseline, right? You got to be able to move. And so having that correlate to say this actually fits the picture that the imaging is painting or not is really interesting. And even just the comparison there, if folks are looking at the screen here, you said it exactly how I describe it, which is like, okay, on these ones where the line is green the whole way, that's pure motion. You did just the thing, right? On these other ones where you see the red line going up, you compensated. And we talk to folks all the time about how the spine compensates when you're out of alignment. And this is measurable. You know, we can see how and why and correlate side to side, right? Sometimes you'll see, you know, let's say they, you know, laterally flex and extend one way, they might do the exact opposite going the other way, right? So it's almost kind of like a crisscross type of a pattern. Others, it's pure one way, but it's just the one side that's dysfunctional. So again, it's interesting data. And I always tell folks, like, we're not going to make too much out of this right now, but we're starting to build a picture of like what's not working well. Because think about this, you know, you can, if you've talked to your patient about their symptoms and about, you know, aggravating and alleviating factors and the situations in which they're symptomatic day to day and the things that are inhibited or, you know, upset by their symptoms. And then you measure something like that. You know, I had a conversation with a lady like this not that long ago, just based on that accessory motion thing without even doing her imaging. I'm like, okay, so you work at a desk, right? Yeah. Do you have like 2 monitors? Yes. How is your workstation set up here? Because like there's definitely some sort of bias in that one side, and it's definitely irritating you. And so we had this conversation just based on this one assessment that made me look smarter than I am about situationally, like, yeah, no wonder your head hurts at the end of every day. It's not necessarily the screen, could be something to do with it, but there's other factors that factor in as well. And I told her, and this is just my take on it, I could be the best adjuster in the world, but if you keep sitting in that condition, if you keep, you know, putting your body in a orientation and a persistent little movement like that that's irritating, it's a little bit more of an uphill battle. So obviously we want to
Absolutely.
build capacity so that you can do your day-to-day life without it having to be arranged just so. But these types of assessments really help, make sense of, day-to-day living conditions, symptoms and dysfunction, what's measurable. We all like to do on our videos, like, have you had all these tests done and there's no results, right? Now we can actually correlate an actual result with the dysfunction that relates to the symptom and make it something that's measurable as an outcome assessment, right? I mean, that's a win-win. So if you're just eyeballing how someone moves their head, you just can't do that. I'm sorry. And even though we use the like easy angle, the digital inclinometer for a
The
while, and that
Melock
was,
device from Instagram. Yeah.
and it was okay. It was a step up, but this is just that much better.
Going
Now,
back to that
there's some.
patient,
Yeah.
like you can also kind of see some abnormal neurological patterns in there because you have this like uncoupled movement where they're laterally flexing their head and they're also turning into that direction, which is an unusual way for someone to do lateral flexion. So it gives
Exactly.
you a sense that like, hey, either they're like avoiding this type of range of motion because there's might be some type of painful issue that's going on there that's preventing them from having a coupled motion, or maybe there is something structurally that you have to kind of factor in, which, obviously cone beam can assess a lot of these issues related to, arthritic joints and some of the degenerative changes that can happen in the spinal canal and things along those lines.
And that's actually a really good segue to like, okay, so we see restriction. Now we need to differentiate between all the things that could potentially create a restriction. And we're biased
Yeah.
towards bones and joints, right? Like, and
course.
inherently, we're very structurally oriented. But when we're thinking through, okay, we know that this is a problem, this particular motion, for example, we understand the compensation there, whether it fits a pattern of normal compensation or not. How do we start to differentiate between, let's say, structural, joint and alignment based restriction versus a muscular or movement based restriction?
I think that's a tough thing. We've never been classically, as far as I remember, there was never a distinction between this is muscular restriction, this is segmental restriction. Like, I don't remember that in biomechanics in chiropractic college. I think all of us in this podcast probably have a better understanding because we've looked at digital motion imaging, right? We've looked at these things to try and understand segmental versus muscular. But even then, I still think we're right. We're kind of like right at the edge of truly understanding that. And there's a perfect example, and it's more from a Blair perspective, right? So more articular. There are patients that I'll have where I will look at the cone beam and they'll have some sort of particular pattern from like an orthogonal standpoint. But if you go and you look at the neutral cone beam and you look at the articulations, let's say like on the left-hand side, you've got a couple things that are okay, and then a couple joints where there's like a pretty significant posterior, like a C3 post PRI. So it's
RILI,
gone.
pick a side.
Yeah, exactly. But then you go and you check range of motion and it's fine, right? You go and you check joint position sense and rotation and it's fine. And it's like, okay, what is this joint?
Right.
Is this malposition really a problem? And it can go
Exactly.
either way, right? And this is where I think the clinician really comes in terms of we have findings, right? And we have symptoms. So how do we treat this patient? Is this misalignment, as we like to call it, the subluxation, or is it somewhere else? And I think I can't believe I'm saying this. This is maybe where there would be that moment in time where it's not all misalignments are, quote, subluxations, right? So you have the data to build into that. But I want to share the screen again because there's something that I think we didn't cover, and I don't think it's something that any of us have really covered. You can do to and from range of motion. So for example,
On the
you
way out and
see
on the way back.
exactly the patient on the way out and on the way back. Honestly, I haven't really looked at this that much, but I think that there's a whole nother treasure trove of, is it, John, and you've talked about doing passive range of motion versus active range of motion and see if we can get like a module to do that. If you see that there's potential dysfunction on active versus passive or passive versus active, you can make a better distinction of, is this is this muscle or is this ligament and or tendon, right? Passive versus active. So I think like truly the sky's the limit with regards to interpreting this data.
Yeah, good point there. So obviously with any assessment, we were trained in this. Like if you want to try to differentiate between like a muscle contractile type of restriction and or joint, like you can do a passive assessment. You can have them wear the headset and you move their head, right? Do one active, see what the patient can produce. Do one passive carefully and see if there are measurable differences. And or mainly for me, when I do stuff like that, it's the quality of the sensation of the movement more than it is how far do they actually go, right? I'm not, pushing the head super far. But I had a situation with a dizzy patient recently who had an episode of neck pain and got very apprehensive and very freaked out by it, right? And so like for her visit, I just did passive ranges of motion with the cervical spine, just desensitizing her to the feeling of moving her head in a way that was, allowed those muscles to like calm down enough to be comfortable again. Because, folks with complicated symptoms, there's a lot that goes into how they feel. And again, like I understood because I had assessed her, done a progress evaluation, knew what her imaging had looked like, had all the, I knew that she wasn't out of adjustment, right? So it was like, okay, you don't need adjusted. You're freaking out. You're in a lot of discomfort because your neck got a little sore and you've had a hard time lately. So it made everything, very sensitized. You can find ways to use this information as a way to understand what to do when, right? I could have just
Sure.
patted her on the back and said, you know what, you're holding, and that means you're healing. But we knew that there was another avenue into helping based on the workup that I had, based on like the clinical presentation of the patient compared to her norm. So those things are invaluable in my opinion, because you never know when someone's going to come in on a visit like that, where it hit the fan randomly and you're like, man, you got to figure something out on the fly. If you have a lot of good intel on the front end, there's less troubleshooting that goes on potentially, or at least gives you that much farther of a head start on it.
I do want to try to clarify a couple things because I think it's easy for a lot of people in our audience who are mostly just strictly doing chiropractic and really just doing adjusting, where I think we could often be in danger of overwhelming people with too much data so that they fail to be able to look at this tool as being useful because, oh, there's way too much stuff here. I can't possibly use something like this. And I would say it's okay for us to strictly use this as an outcomes assessment in the very beginning, just to measure what the outcomes of our care are. But then as you re-examine someone, so like I try to make a point to like re-examine someone at least once every 2 to 4 weeks when they're going through their initial phase of care. And during that initial phase of care, you might just be adjusting someone, and there's nothing wrong with that because that's your best tool in your toolbox. That's how you know how to troubleshoot. And while you're just adjusting that person, and let's say that like they are feeling great, and even if their NeckCare accessory ranges of motion aren't looking any better, that's still probably fine, right? But now we have the patient that's on the flip side where they are not doing so well. You feel like you're doing a really good job chiropractically. Where else can I look at that can see, all right, where am I possibly missing something? So then, like, all right, you didn't have to like spend excessive amounts of time on your initial assessment of reading NeckCare data. You just have it and you're ready to go. But now that the patient is struggling and you want to try to help them, let's go back through the data. Let's look at their pre versus their post. And especially if you notice that there's a consistency in that accessory range of motion data, that's just like, yeah, this person has like a pretty messed up lateral flexion. Why might that be the case? And then you could start to look at things from not just your strict technique lens, but take in all the information that you've gotten from, continuing education, from learning other techniques that you probably forgot about in chiropractic school that might be applicable now. And you can start to use those things and say, hey, does this affect this obviously bad range of motion, accessory range of motion? And does that end up leading that patient to get better? So that way you don't have to feel overwhelmed when you're just looking at this initially and feel confused about what you have to do with all this data, which, when I first looked at it, it was quite overwhelming. But now when I look at it in the context of like, all right, let me do my thing. Let me do what I know is best based on how I practice. And now I have another route to troubleshoot a patient who might be struggling.
Yeah, that I didn't really interpret a whole lot for the first 6 months. I was just trying to get enough pre and post assessments to start to see like what am I actually even doing, because folks are getting good results, right? They're feeling good, all the things, right? All the upper cervical accomplished, objectives. What does that mean, with this? And then to your point, is there something else to be done? And I usually tell folks in the beginning, like, we're just assessing function here. We're getting a baseline, right? Really, it only needs to change as much as it needs to change for your quality of life to get better. And for all of our other things to, like, this is just information to help us move in that direction. This is not like a test that, just like posture alignment, if it's not perfect, if you don't hit green bars on all your ranges of motion, you're not going to be okay. That's not the case at all. And so I guess that's a good point of caution too, to like maybe not oversell the test and make a big deal out of it. We're assessing baseline function. We are wanting to test broad so we can zero in on the strategies that make the most sense and have thoughtful ways to select in and out strategies that, to your point, Doc, may take us that much further down the road if we need to. But a lot of times, if you're feeling well and you're functioning well, that's good enough, right? It all is in the context of how you practice, like your exam flow and your communication style and what your main objectives are too. So yeah, good advice. It's just test and measure, right? Get yourself some reps with pre and post assessments and observe what's actually going on. Maybe don't overemphasize it, initially, and just use it, and we talked to Dr. Schulten about this. I know you did, Cameron. It's like for a while, you just kind of test it and you watch and you see, like, what am I getting here? How's this going? And that's great. The same with posture or anything else.
Well, and there's
100%.
something else that I realized early on, even with range of motion, especially if you're tracking this now, you have to be okay with getting suboptimal results, or at least initially, in terms of if you do a treatment and you reevaluate. At least how I explain to patients is, we're looking for change. We need to be able to see that your system can adapt. And some of these things, like one range of motion may get a little bit more restricted. We may see that there's more range of motion in another. And that's okay. This is why we have this data. So as you change, we can keep a pulse on it and we can change with it. But there's plenty of times where I've done pre and post adjustment, which actually I don't do very much anymore for various reasons, but I've done a pre and post adjustment, and you'll see that one thing gets wildly better. And then you have a couple other things that get moderately worse. That freaked me out at first. And then I took a step back. I talked to some folks, actually talked with some of the folks at NeckCare on their development team and their researchers. And they said, that's actually something we've seen as well. And it literally is just when you treat the cervical spine and you change the tone of the muscles, right, you're going to get a different functional change. You might get more range of motion in one plane or less range of motion in another. And they confirmed, like, it's not necessarily a bad thing or a negative thing. It's just that there was change that happened. And that kind of kept me, because exactly. And that's especially if you do it post adjustment, like immediate post adjustment, as opposed to, like Chung said, you do it 2 weeks or 4 weeks. Don't freak out, gather the data. And then if you realize that there's more complexity, just like Chung said, then you can go back and take a deeper dive. You don't have to start 10 miles deep. You can start right at the surface level.
And this is a good point that I picked up just from, watching Tran go through her lupus journey, because it's given me this strong insight into, like, all right, how do medical doctors take all this massive amounts of data that they're getting from a blood test? And there will be times where, like, Tran's doing well and, like, oh, her liver enzymes are a little bit elevated right now. Does that mean the drug is bad for her? Does that mean all this stuff? And, like, the doctor's like, no, like, the body changes all the time. And these are snapshots of what her body is doing right now. Like, we want to see global trends of her autoimmune markers coming down. And as long as we're seeing that, we don't worry about if, her antibody levels are like 2 points higher than they were 3 months ago. That's essentially the same thing. But when we look at where she was 2 years ago versus now, there's a clear trend that her autoimmune markers are much better. And that's, like, in chiropractic, we lose sight of that, right? Because, like, we get a little bit anxious about retesting people because we're worried about, what if that range of motion, or what if this balance test looks like it's like 3 centimeters worse than it was before? Like, the patient's going to hold us accountable to that. And like, see the big picture, like, allow yourself to measure the trends over time, because that's what really matters, because anyone can change on any given test from a day-to-day basis based on how crappy you slept that day. Did you have a recent non-related orthopedic injury? Like, did you hurt your shoulder 2 weeks ago when you were originally coming in for back pain? Did you have all these other factors that are going to affect what you are seeing on that test? Because remember, we're not measuring subluxation on these tests.
Correct.
And I know people are trying to use this to say, like, we're measuring subluxation. This is not what this is about. This is about measuring the global health of the neck as a whole and their response to our care for them as a measurement of, is their global neck health getting better?
Yeah.
Beautiful.
That's a great point, because this conversation came up about, like, is this something we could use for pattern analysis, right? And, similar to how folks would use thermography. And my first thought was like, I understand where you're coming from, because we have this inclination to think that that pattern means something historically. But to your point, like even with thermography, I'm like, I don't think I want a pattern, right? Like, we want physiology to be adaptable. Like, it's not the thing that we're after. Is like, how do we identify a consistent, exact, measure of dysfunction every time the patient needs adjusted, right? I tell folks all the time, like, even if I see you in a week, there's a lot of life that happens between now and then. I mean, for myself, and I'm assuming for you too, right? So, any data we collect is exactly for that reason. It's like, what are the trends over time? Can we notice things moving in the direction that we intend to get you where you need to go? And what is inhibiting our progress if we're not, and that whole conversation about patterning, it's got me thinking differently about whether that should be such a big deal in the first place, which is, probably chiropractic heresy. But even that thermography pattern, it's got to have more to do with, the anatomy of the capillary beds than the actual nervous system. But
it would be interesting to potentially just experiment, and if he's listening, maybe he'll do this. But it would be an interesting experiment to maybe do just like with a Titron, 3 scans over a period of time. You get, like, do range of motion. You do 3 reps. You do it as a first test, and before they leave, you do it again. And then before you adjust them at the next visit, if that's what you do it again. And you get an idea of, is there a commonality or a trend? Just like Chung said, in terms of the medical stuff, snapshot in time. We're no different. Chiropractic, taking a static x-ray at a random point on a Tuesday when it fit their schedule, isn't necessarily indicative of, like, the silent killer with regards to
correlating
pressure
it
on
to
the
your
heart
birth
nerve.
trauma.
Yeah. So, like, it's this I think we're all saying the same thing, and it's a great way to land the plane on range of motion. Is it's a metric, right? Use it in how you see it relative to your practice and your practice style, but be open to potentially exploring more and using the data in the more complex cases that maybe didn't respond in the way that we anticipated, digging back into the data that NeckCare range of motion provides, and then saying, okay, now that we see this and understand this, we can treat this patient to a deeper level, which would hopefully get them to where they want to go.
And just as a further landing the plane, Cameron, I think it would be a good idea, just for the folks that are maybe not clear. Like, when you're looking at these assessments, how might you think about different regions of the spine, of the cervical spine, relative to these different ranges of motion? So folks are going, okay, big deal. I see like a compensation with lateral flexion. Like, what does that even mean?
Yeah. And that's
General.
I'm gonna keep it general, because I think that there's a huge, I know, I'm sorry. I'm gonna try.
You have to go to the orthospinology symposium to hear the not general explanation of this.
Or the postgrad DC, or the upper cervical symposium ICA, because I'm talking about it a lot this year. But I think if we understand biomechanics from a global perspective, in that initial movements of the head and the neck most likely occur at the craniocervical junction relative to lateral flexion and rotation. If you see on the NeckCare range of motion that this patient deviates almost immediately or within the 0 to 20 and then it gets better, maybe you could say, okay, could use this as a guide of, there could be more of an upper cervical issue here, as opposed to they just have a global neck issue. And if you have imaging, you can correlate it, right? As opposed to something, let's say rotation, they go off the rails and they compensate in lateral flexion with rotation, or vice versa, at 40 degrees or beyond. That's more than likely a mid to lower cervical issue, at least from understanding digital motion x-rays and understanding stress scans. So, like, again, you can keep it as broad as you want, or you can get minute to really try and dig in and, like, oh, this person potentially has a left, lateral flexion restriction, most likely at C4, C5, based on the range of motion data. You can go and correlate it with your x-ray and show that they have some sort of arthritic change at that, or they have some sort of postural distortion that really cruxes at that particular joint. So it comes down to just synthesization.
And we see lots of folks with degenerated joints, right? We see lots of folks with degenerated discs. We see a lot of asymmetry in the shapes and angulations of the articulation side to side. So it does, again, to both of your points, in terms of what's considered normal, and like what is the outcome that we're trying to achieve with this particular motion assessment. Lots of filters that needs to be passed through to understand, in each patient's circumstance, what's a reasonable level of improvement that's going to get us where we want to go, right? If someone's severely degenerated, I don't say, we really got to get you to that green bar, right? It's like, hey, let's do the best with what we have, right? Let's make it comfortable. Let's make it workable for your day-to-day life. We understand there's probably going to be some sustained restriction there. I don't care what anybody says. Adjustments don't like reverse arthritis, and it's okay. They don't have to. But it does give us, again, to your point, gives us a way to at least gain insights into how is the spine working, right? How does that correlate with the other associated tissues and systems, which we're going to get into with these other assessments? And what progress can we measure over time? So the range of motion, I think, is at a baseline, such a good entry point into a better understanding of the health and the function of the cervical spine. And with this accessory motion, with these abilities to like see them coming and going, with all the robust data that NeckCare has to offer, it opens the door to a lot of potential insights. And I think that's the main point that we'd like to make is with the information as it comes along, just like the leap from digital x-ray to CBCT, there's going to be questions about what to do with this information, right? We're going to have to try to, make sense of the pros and cons of our technique perspectives and our assumptions based on the data, but at least it gives us the opportunity to do so. So as far as range of motion goes, I think that's a great way to wind it down. And this will come back up and later in the conversation, like as we're thinking about correlating findings across these assessments. So listen in for part 2 and part 3. We're going to break down or at least approach joint position sense or joint position error testing, and also sensory motor control with the butterfly test. So I'll look out for those future episodes. And listen, observe, watch, go to YouTube and see the assessments. And if you have questions, our contact information is here in the show notes. Reach out. Like, we like talking about this stuff and we'd love to have more discussions about it.